Let's talk about what is the treatment outline if a patient with burns comes to us in our emergency department. See here. Now, airway, breathing, and circulation has to be managed first because sometimes this burn can, damage the airway. And one of the very common explanation for this is swelling or edema of the airway is quite common in case of burns. If the person is trapped inside a room or inside the house where there is a lot of flames, that type of burn, then there may be serious injury to the airway. So airway has to be secured, and that is done by intubation. Intubate the patient if indicated. After that, take care of breathing, and circulation is very, very important here because the person will lose a lot of fluid from the body. And why? Why the fluid is lost in case of burn? What is the mechanism? Yes? Who can answer this? Anybody? Why fluid is lost from the body in case of burns?
The skin layer is the tight seat for the water. So if the skin layer are damaged, so water can be lost through that.
Very good. Good answer. Excellent. Okay, that's what I want. This exact answer he has given because the skin is preventing the loss of water from our body. If skin is gone, that protective layer is also gone. So there is a massive evaporation of the fluid from the surface of the body, which can result in hypovolemia very soon. So fluid resuscitation is absolutely necessary in the treatment of burns. Never forget this. Okay, this is probably the most important treatment in case of severe burns. So start fluid resuscitation with 1 liter of lactated ringer in adult, which is given as a bolus, and 20 ml per kg for children in the emergency department. So this type of discussion we have already done in many different, topics, isn't it? See this. 1 liter of lactated ringer bolus in adult and 20 ml per kg for children in the emergency department. Remember, this is just the beginning. Later on, we need to calculate what is the total amount of fluid in 24 hours by Parkland's formula or Galveston formula. Then we should continue giving fluid. We'll talk about that. Now, what we do after that? See here. If carbon monoxide inhalation is suspected, administer 100% oxygen because carbon monoxide poisoning is so common in case of burns. Okay, so oxygen is the antidote for carbon monoxide poisoning. Always remember this. So give oxygen, pure oxygen in high flow. Assess area of burn, and we already know how to do that. This is done by rule of 9. You can do this in 2nd and 3rd degree burn. In 1st degree burn, we don't use that formula because it is very, very superficial. All burn patients need good analgesia, and that is provided by IV morphine. This is a very strong analgesic, opioid analgesic. So ordinary type of NSAID may not work here because this is a very painful condition. So give a good dose of morphine. Apply cold saline soaks for analgesia if burns are less than 25% of body surface area. But remember, you are applying cold, thing on the body surface. So watch for hypothermia if you do this. But there is advantage of cold saline soak. They produce analgesia. They decrease the pain which is occurring in those burned area. But at the same time, we should watch for hypothermia. What is hypothermia? What do you mean by that?
Decrease body temperature.
Hypothermia is when the body temperature is less than 36 degrees centigrade.
Decrease in body temperature causes cold.
Exactly. You can simply say less body temperature or decreased body temperature. There are different classification. Okay, mild hypothermia, moderate, and severe. Let's not go into there now, but that is the definition. Very good. So that is the real danger if we apply a lot of cold saline soaks. Cover burns with silver sulfur diazine or clean sheet and then warm blanket. The silver sulfadiazine is the local antimicrobial agent. It is available in the cream form or in the ointment form. So we apply nicely over the burned area and then cover it up. Okay. Elevate the burned area when possible to minimize edema. This edema is causing a lot of secondary effect there. So if edema is there, then just try to decrease it by elevating the burned area. That is another basic, treatment outline. Let's move on. Now, order some of the basic lab there. Okay, some of the basic lab like ABG, complete blood count, CBC, serum electrolyte level, and even carboxyhemoglobin. So all these things you have to do. So ABG, because the person may be in hypovolemic shock, and in case of hypovolemic shock, the person may develop metabolic acidosis, which is diagnosed by arterial blood gas analysis. This is an important one in case of a serious type of burns, okay, not in milder type of burns. Please mute yourself. Weigh the patient. Now take the weight of the patient. This is important. Take the weight of the patient, because according to the body weight, okay, we can calculate how much fluid patient need. Continue the fluid resuscitation as per the Parkland formula. Sorry, as per the Parkland formula. Now you may be wondering, what is this Parkland formula? Well, we are going to talk in detail, and I will ask you to calculate some of the, formula or examples also right here when we discuss it. Okay, Parkland formula. Insert Foley's catheter in patient requiring fluid resuscitation or with significant perineal burns. Now, Foley's catheter, okay, will show us how much urine the patient is producing. Now remember, severe type of burns can easily lead to dehydration or hypovolemia. And when we resuscitate them with fluid, we should make sure the kidneys are functioning well. And that is known by a good amount of urine output. So Foley catheter has to be kept there. And in case of severe or significant perineal burns, the urethra may be damaged. Okay, the urethra may be damaged. And if we do not put any Foley's catheter there, then there may be a lot of scar formation in that area. And remember that scar, okay, will altogether obliterate the passage of urethra. So just to avoid that, Foley's catheter is really necessary in the management of perineal burn. And in other type of severe burns, we can go for Foley's catheter to monitor the urine output. Now, ECG, okay, or EKG, ECG in British English, EKG they say in American. We don't care about it. Whatever terminology you use, that would be correct. So this is an important one, because these are the serious patients. There may be severe damage in the body. There may be hyperkalemia. Hyperkalemia has the effect in the heart. We have already studied that. If this is a case of electrical burn, okay, and then there may be severe damage to the heart. So ECG is one of the important investigation. Put NG tube for extensive burns, because there is a chance of curling ulcer formation, and this curling ulcer may lead to bleeding. So if I put NG tube there, and if a fresh blood keep on coming, that means there is active ulcer going on. Okay, so this is a very important information. Curling ulcer, don't forget it. This is a stress type of ulcer which is developed in our GI tract as a result of burns. Very important MCQ question. Now, patients with high voltage electrical injury require cardiac monitor, as do any intubated or otherwise unstable patient. Cardiac monitor means this is a monitor which can, have the reading of so many different vital signs there, like what is the heart rate, what is the respiratory rate, what is the blood pressure, what is the temperature, okay, what is the pulse oximetry. Everything is shown in a monitor, and these are important in a sick patient. These are just the outline though, okay? So we are going to talk about in detail. Let's move on. Now, how to decide who may be treated as outpatient? Now, all burns cases we cannot admit in the hospital. There are different categories of the burn: first degree, second degree, third degree. So, how to decide who may be treated as outpatient? And the answer is most first degree burns are treated as outpatient. We don't need to admit them. Some superficial and intermediate second degree burns, which have less than 10% body surface area, can also be treated as outpatient. So see this, superficial and intermediate second degree burns, less than 10% body surface area. But there are certain exceptions here. Burns of the face, burns of the eyes, burns of the hand, and burns of the perineum are admitted in the hospital even from this category, because there is a high chance of complication development in the burns of those area. If burns occurring on the anterior parts of the chest, anterior abdominal wall, on the back, okay, on the thigh, something like that, then we can treat this patient as outpatient, especially if the body surface area is less than 10%. Now, I am entering into the very important part. So I want students, please pay attention a little bit more here. So how to calculate the fluid and how to give to the patient in case of burn. See there. Okay. Now we use Parkland formula. Parkland formula. And this Parkland formula is mainly used for adults, and it calculates the fluid for first 24 hours. That is the most critical period. So how to calculate? Ringer lactate or lactated ringer, okay? LR means lactated ringer is the fluid which we give, and how much fluid? This is the calculation. 4 ml multiplied by body weight in kg of the patient, and we again multiply this by percentage of the total body surface area burns. Now, how we calculate this percentage of total body surface area burns? Yes, how to calculate this?
Rule of nine, sir.
Rule of 9.
Exactly.
Because every part is already given in short percentages, and we multiply that area.
Exactly. So you don't need to worry about that, okay? Even if you are confused, what is the total body surface area of those burn? You have got all the chart, okay, in the burn ward or in the emergency department of the hospital. You can quickly look there and calculate what is the percentage of total body surface area burns. So the simple answer is rule of 9 is followed here. That is most commonly employed one. Now, after you calculate the total amount of fluid, give half of the 24-hour requirement in first 8 hours, okay, from the time of burn, and remainder is given over the next 16 hours. Remember the management I taught you in severe dehydration. It is a bit similar. Okay, it is a bit similar. The total amount of fluid calculation was different there, but how we give is a bit similar. In that situation also, we give half of the fluid in first 8 hours and half of the remaining fluid in next 16 hours. And we need to give bolus also. So similar type of situation here. So this is Parkland formula. 4 ml multiplied by body weight, and we multiply that again by percentage of total body surface area burns. Now, in case of pediatric patient, what we do? In pediatric patient, we use Galveston formula. Okay, Galveston formula, and this Galveston formula is also known as Shriners Burns Hospital Galveston formula, because this formula is devised by this hospital for the first time. You can simply remember Galveston formula. Now, according to Galveston formula, we provide 5,000 ml per meter square body surface area burn as a resuscitation fluid and 2000 ml per meter square total body surface area as a maintenance fluid. So maintenance fluid is added, okay, along with body surface area burn requirement. So this is Galveston formula. As with the previously described adult formula, half is given over the first 8 hours and the remainder is given over the next 16 hours. Now, this is a little bit difficult for the students in the beginning to understand, but make your concept quite clear here. How much body surface area is burned? If 10% body surface area is burned, okay, I multiply that by 10 here, and then add another, okay, 2000 ml about the total body surface area. Now there are charts available. What is the weight and what is the body surface area relation? We have certain chart. So accordingly, what is the body surface area that child is having? We can easily calculate and do the necessary thing. Now, after giving fluid, what you should monitor? Whether urine output is enough or not. Never forget this. Resuscitation is adequate when urine output is 30 to 50 ml or cc per hour in adult and 1 ml or cc per kg per hour in children who are less than 30 kg. More than 30 kg, we almost follow it like adult. So it means good amount of urine must be produced. Now, what is the danger? Uh, if the kidney do not get enough blood because of hypovolemia, what is the danger of that?
It's a kidney failure, sir.
Hemodynamic
May lead to renal
perfusion
failure.
may lead to cardiac heart failure.
Okay, so this is known as renal failure. This is pre-renal failure. Remember this. There are 3 types of renal failure: pre-renal failure, intrinsic renal failure, and post-renal failure. This is pre-renal, when kidneys are not getting enough blood flow or enough perfusion. They fail. To avoid that situation, okay, you have to give enough IV fluid and monitor for the good urine output. That means kidneys are still functioning well. This is the whole idea. Monitor daily weight. Now, why should we monitor daily weight now? Yes, what is the reason for this? Anybody? It's a very easy answer. Sometimes yes, please.
Due to volume loss, there is also a decrease in weight.
Okay, good. That is one good answer. And another one is you are giving good amount of fluid. Sometimes you may have given a lot of extra fluid that can lead to collection of the fluid in the body, and that can cause pulmonary edema and brain edema. Okay, let's just think about a situation. The patient was brought to the hospital very late. The pre-renal failure is already converted into intrinsic renal failure. Now, during that time, I cannot give fluid to the patient. I should restrict the fluid. If I give, there is a high chance of collection of the fluid in the body, leading to pulmonary edema. Now, all these things you know by monitoring daily weight. If excessive weight gain is there, that means fluid is collected in the body. If a person is still having loss of weight, that means fluid is not enough in the body. Okay, so daily weight measurement is a very good point in the burn ward. Now, in this situation, there is increase in fluid requirement, like high voltage electrical injury, inhalational injury, delayed resuscitation, and intoxicated at the time of injury. Intoxicated means probably the person was under the effect of alcohol, okay, at the time of injury. We all know alcohol makes the patient dehydrated. So all these are a situation where there is increase in fluid requirement. High voltage electrical injury, okay, very serious type of burn, inhalational injury, delayed resuscitation, and intoxicated at the time of injury. Let's move on. Now, One of the important point, bone patients are susceptible to Curling's ulcer. Curling's ulcer is a type of stress ulcer, occurs in the stomach or first part of the duodenum. So to prevent this Curling ulcer from the development, what should we do? Yes, what should we do now? The patient is already admitted in the hospital, okay? Patient may develop this Curling ulcer. So what should we do? Which drug we give to the patient so that the Curling's ulcer will not form there? Any answer?
Sir, we can give the antacid therapy as well,
Sir,
sir,
we
and
can
some
give
antibiotics.
proton pump inhibitor.
Exactly. Okay, so don't get nervous by getting this type of question. Your answer, you all know, every student know already. The answers are the same drug which you give for peptic ulcer or gastritis, right from the H2 receptor blocker, PPI, okay, those type of medicine. They are the most commonly used drug, isn't it? H2 receptor blocker like ranitidine, cimetidine, famotidine, nizatidine, all those drugs, and then PPI, omeprazole, lansoprazole, pantoprazole, and all those drugs. You can use other drugs as well. There are so many different groups. Let's move on. Another important point, everyone who are involved in the care of the newly arrived bone patient should use a sterile technique even when simply examining the patient, because the risk of infection is extremely high with skin loss. Skin is a protective layer there. Skin is protecting from the entry of microorganisms inside the body. Now that skin is lost. So any type of microbe, whatever are present in the environment, on the patient's hand and all those things can easily get entry into the body. So we need to be careful. So what do you mean by that? Use the gloves, sterile gloves, and examine the patient. Discard that gloves after you finish examining the patient. So all these things has to be followed. Wear a cap, wear a mask, wear a gown if possible. So these are the important point. Now, please, okay, be ready with paper and pen in front of you. Now you are going to calculate, okay, some of the fluid requirement according to Parkland's formula. Now, see this. This is a scenario A. An adult male is brought to the emergency department, ED is emergency department, with second-degree burns on his chest and abdominal wall, anterior right leg, and perineum as well. What percentage of total body surface area burns does he have? Okay. So what is the total percentage of body surface area the person is burning? Just calculate it. Okay, I'll give you a bit of time for this. If you are confused, okay, go back with that rule of 9 and calculate right now. Anybody? Anybody is ready?
Yes, sir. 28%, sir. The chest is about 18%, and leg is 9%, and perineum 1%, equal to, sir, 28.
Yes, sir, same, sir, same.
Good, good, very good explanation. I'm sure many of the students are following that, right? Yes. Okay. So this is the exact way how we calculate the total percentage of the body surface area. Now see here, chest. Okay. See this, chest and abdominal wall. Okay. The chest and the abdominal wall is 18%. This is 18% burn. Anterior right leg is 9%. So 18 plus 9 is 27, and perineum is 1%. Absolutely correct. So this is 28% of the total body surface area burn. And this is a second degree burn, which is already given. Now, can you tell me how much fluid this person needs? But we need a weight for this person. Okay. So let's say the weight of this person is 50 kg. So can you calculate the fluid requirement according to Parkland's formula now? The body surface area burned is 28% and his weight is 50 kg. Calculate, please.
Sir, 5,600 milliliters, sir.
Good. So let me write that for you here. Okay. The 28% body surface area is burned. Okay, and weight of this person is 50 kg. Now, Ujair, can you repeat it again? How much the fluid requirement you have calculated? Yes.
Sir, 5,600.
5,600. So let's follow the Parkland's formula here. 4 multiplied by 28 multiplied by 50 kg, and that will give you the total milliliter or cc of the fluid. So you just calculate it. You get your answer right there. Okay, so see that 4 multiplied by 28 multiplied by 50 is 5,600 ml of the fluid. You should know how you got that. Okay, then only you can solve it next time. Otherwise, you'll always get confused. Now, how we give this fluid? We divide this fluid into two parts. Okay, 5,600 divided by 2 is 2,800. So we give 2,800 ml in the first 8 hours, and then remaining 2,800 ml in the next 16 hours. So this is the way. Now, let me make sure that every student know this Parkland formula quite well. Let's go to the scenario B now. How much fluid should a 60 kg female with a 25% total body surface area burn receive during the first 24 hours? All of you, please do this.
6,000.
6,000.
6,000. Okay, so every students can do that. Simply multiply 4. Okay, multiply by 60, multiply by 25. So it would be 6,000. So divide that into two parts. 3,000 in first 8 hours, 3,000 in remaining 18 hours. Sorry, 16 hours. So that's the way. Let's move on. Now see this, to make it quite clear. Okay, let me show you the this slide which is showing us the answer. The rule of 9 says 18% for anterior torso, that is anterior chest and anterior abdominal wall, 9% for the anterior leg, and 1% for the perineum. Total would be 28%. We have done that quite correctly. And the answer B, Parkland's formula, 4 ml, okay, multiplied by 60 kg, multiplied by 25% of the total body surface area burned. So it would be 6,000 ml, means 6 liter of the fluid required for the next 24 hours. And we divide this and give ml per hour to the patient. That is done by the nurses. We just simply order this much fluid you have to give in this many hours, and the nurse will simply give that much of fluid. Okay, this is the way. Let's move on. Now, after knowing this very important part, now how to take care of this burn on a daily basis. What should we do in the burn ward or burn unit? Every day when we are following up the case, we check ABC again, airway, breathing, and circulation. Okay, we have to check because some of the patients are seriously burned, and if necessary, do physiological resuscitation. If the patient needs fluid, give the fluid. If the patient needs to protect the airway, we need to do that. Cleanse wound and trim the non-viable skin, very important part of the burn care. Clean the wound every day and trim the non-viable skin, debride that area. If some skins are already necrosed, okay, remove them. Apply topical antimicrobial agent for burn wound care. So these are certain antimicrobial agents which we are going to talk. What are those? Okay, so we have to use them, like silver sulfur diazine. Okay, mefenide acetate. These are certain drugs which we are going to use. We'll talk about them later. Now, what is the definitive therapy of the burn? For definite non-excisional therapy, continue daily cleansing and debridement until granulation tissue is present with minimal or no necrotic debris, at which time a biological dressing is applied. Now listen carefully. This is a very easy concept here. So sometimes the burn is very severe there, like okay, 3rd-degree burn. A deeper area is affected. So we need to remove all those dead and devitalized tissue from there. That is called debridement. Okay, we have done that. Now there is a big area which is exposed outside. There's no skin now. So what should we do? After the granulation tissue or healthy granulation tissue is present, we should cover that wound or that area up. This is done by skin graft. Skin graft. The skin is taken from some other areas of the patient's body and grafted over there. This is the most common way. Sometimes skin from another person can also be kept there. And sometimes some artificial skin-like tissues can also be kept there. So all of these are known as biologic dressing. And there are certain operative therapy also, like sclerotomy. We have done that or discussed that before in the last class. And we again will talk about that. Sometimes there is compartment syndrome develops because of severe edema, because of necrosis of those particular tissues there. We have to go for fasciotomy. So these all are different type of operations which we need to do in case of burn case. Now, what are these? Antibiotic or local antibiotic which you apply on the surface of the burned area. Now, look at the name here. Okay, these are the important point. Silver sulfadiazine is very commonly used. Triple antibiotic ointment. The triple means it has got 3 components: bacitracin, neomycin, and polymyxin B. All of these are antimicrobial substance. Okay, and mefenide acetate. Mefenide acetate is another one. So silver sulfadiazine is indicated for general management of the burns with no scar present. Now scar means it is a type of membrane which is collected at the surface of the burnt area, and it mainly comprises of dead and devitalized tissue there. Okay, so you need to remove that scar. Then below the scar there will be granulation tissue, and those granulation tissues should be a healthy one. So silver sulfadiazine is indicated for general management of the burns with no scar present. You need to remove the scar, then apply it. Triple antibiotic ointment is indicated for general management of the burns of the face usually. And mefenide acetate is indicated for deeper burn with scar present. So it can be applied even with the scar, and we should use it sparingly. Okay, it is not very commonly used, probably because of some of the side effects. Now, a little bit of information regarding, these different types of antimicrobials which are used. Now, another microbial which is, shown here is silver nitrate, mefenide acetate, and silver sulfadiazine. You have already seen the name. So see there. So we are not going into detail regarding each of them. You can always follow this later on when you are, you are having a bit of more time. Okay. So these are the active component of these topical agents, and this is important here. Spectrum of antimicrobial activity. Like see there, against gram-negative organism, it has a good coverage. Against gram-positive also good. Against fungus like yeast also, it has a good coverage. This is silver nitrate. Mefenide acetate, okay, against gram-negative bacilli or gram-negative bacteria, I should say, good. Gram-positive coverage is also good, but yeast coverage is poor. Whereas silver sulfadiazine, okay, gram-negative is a bit variable, gram-positive is good, and yeast coverage is also good. So these are certain things. Now, method of wound care, this is the way, and these are the advantages of these different types of substances. Now let me go and talk a little bit about the silver sulfur diazine because it is very, very commonly used in the clinical practice. So when we apply this, it is a painless application. Okay, it is a painless. It's easily applied on the wound surface. But remember, you need to remove the scar from the surface of the wound, expose that area. Okay, then apply the medicine. And these are some of the disadvantages of these drugs. Okay, you can see this a bit later, but let me highlight the important one only. Neutropenia and thrombocytopenia are some of the important adverse effects of silver sulfur diazine. Now remember, this drug belongs to sulfonamide group. So these are the important side effects of sulfonamide group. Hypersensitivity is infrequent, but it can happen in some of the cases. And it has a very limited scar penetration. That's why we need to remove the scar and then apply the medicine. One important question which may be asked to the student in MCQ exam, see this, silver nitrate. This has a silver substance there. So one of the side effects is called argyria. This argyria is a rare condition which causes the skin to turn blue or gray. And this discoloration happens when the body comes into contact with excessive amount of silver. Because the medicine contains silver, so this may be a side effect there. Okay. So these are some of the important. Now, another part which I like to highlight here. Oh, okay.
Sir, allow me.
Yeah, sure. Fine. The risk of infection of burn tissue is increased. We already know that. Okay, already know that. That's why when we examine these patients who have exposed tissue, we should maintain very strict aseptic precaution. Use the glove, which should be sterile one, and all your clothes should be sterile. This is the first thing. Another important point, why there is a high chance of infection there? Because of the presence of protein-rich exudate and the moist area there. These are good culture medium for the bacteria. Now, if these are good culture medium for the bacteria, what does that mean? Bacteria can easily grow there and can lead to secondary infection. Another point, the scar. New scar means new scar formation there, and lack of vascularity also limit antibiotic delivery to the affected area. So if antibiotic cannot penetrate those affected area, then also there is a high chance of infection or spread of the infection, and they cannot be controlled easily. Now let's come to the practical point here. In a burn unit, if you visit or if you work there, there are high chances of secondary bacterial infection caused by staphylococci, caused by a Klebsiella, Proteus, and all those things there. Okay, and sometimes even fungal infections are quite common. So these are the important point. Hypovolemia and hemoconcentration can lead to elevated hematocrit and decrease left ventricular end diastolic volume that result in decreased cardiac output and low flow state. This mechanism, I believe every student know already. Why hypovolemia leads to decreased cardiac output? This is the mechanism. Hypovolemia can lead to decreased venous return. Decreased venous return can lead to decreased end diastolic volume. And that is responsible for the stroke volume. When stroke volume is less, the cardiac output will be less. Okay, so this is just an explanation given for that condition. Let's move on. Now, there are certain operations which we do in case of burns. These operations are sclerotomy and fasciotomy. These are the important ones. Later on, in a very late stage, if there is extensive scar formation, very disfiguring scar, sometimes those scar can badly damage the function of the joint also. Then we can do certain plastic surgery to remove those scar also. So that is also can be considered as operation in burns. But let's talk about this now. Sclerotomy, these are the certain indications: impairment of circulation in extremities, impaired ventilation, and there's no anesthesia needed there. These are the indication for sclerotomy. Means this can be easily done, okay, in severe, not in severe type of cases. Now see there, these are the areas where sclerotomy can be done. These are the areas where incisions can be given easily. The incisions are placed along the medial lines of the extremity and the thorax. You can see this dashed line here, okay, these dashed lines. And you can see some of the lines are a little bit bolder also, just near the joint. See, this is the wrist joint, this is the elbow joint, isn't it? The lines are bolder. So in this area, if burns occur, we need to go for this procedure quite early, because these are the area which will damage the function of the joint. If some contracture forms here, we'll lose the function of the joint when the joint is still fine. For example, the elbow joint, the lower end of the humerus and the upper end of the ulna are still normal, but still, because of this tightening of the skin, we cannot, uh, you know, produce the function of the joint. These are quite important points. So what's the knowledge here? We have to go for early sclerotomy so that these scars are not formed later on. Fasciotomy. If sclerotomy fails, you need to go for fasciotomy. Especially fasciotomy is done if there is a risk of compartment syndrome. Now, let me ask this question. What is compartment syndrome? Who can answer? Anyone?
Sir, in compartment syndrome, there
During
is
compartment,
increased pressure in
Good, good,
sir,
good, good.
increased pressure in
the pressure within the muscle is
increase
elevated, sir, which will reduce level, sir,
Pressure
which,
build up with
sir, which can give us decreased blood flow and causing ischemia in that area, sir.
Yes,
pressure within the muscles builds to dangerous level.
exactly. Many students are speaking at the same time, but still I got their meaning. Okay, good. All of the answers are correct. Listen now. There's a compartment inside in the limbs, especially we're talking in the limb, like upper limb or the lower limb. Remember, these compartments are formed mainly by the attachment of the fascia, okay, with the bones. And sometimes there are multiple bones present in our limbs. If I take example of forearm, there are two bones present, radius and ulna. If I take example of leg, there are again two bones, tibia and fibula. And there is one strong interosseous membrane which is attached between these two bones. So all these things, separate that area into different compartment. Now let's come to the point here. If that compartment is having excessive pressure, that pressure may be because of the swollen muscles there, that pressure may be ischemia of that area, infection of that area, okay, all those things, then the blood circulation, which is distal to that area, would be compromised because of excessive pressure. What will happen to the arteries? They are compressed. So this condition is known as compartment syndrome. So this may be one of the complications of the burns, but it is not only seen in the burns. It is seen in fracture case very commonly. It is seen in extensive muscle injury also. Okay, so all those points are there. So what is the treatment now? Fasciotomy. You cut that fascia, allow that pressure to go outside, and everything will be all right. But fasciotomy is a bit of serious type of surgery, so general anesthesia is required here. Whereas in sclerotomy, you don't need general anesthesia in the patient. Now, some minor type of operation which we do, okay, is debridement. This is debridement. See here. This debridement is removal of dead and devitalized tissue. And later on, the healthy granulation tissue will fill that area, and after that, the patient is fit for skin graft. So I'm providing a very good concept here, okay? So many things are written here. If you cannot remember those, it's fine, but remember the concept. Why debridement is done and when is the time for skin graft? The time for skin graft is when the healthy granulation tissue fills that area. And we all know What are the criteria for healthy granulation tissue? It looks red or pink. When we touch a little bit, there may be easy bleeding from that area. Okay, these are the signs of healthy granulation tissue. After that only, go for skin graft. Never put skin graft in an infected area. Never. That skin will be rejected. The skin will never take there. Now let's come to the slide. Excisional treatment is indicated for most deep second and third degree burns once the patient is stabilized. This is known as debridement. Advantages are decreased length of hospital stay, earlier return to work, decreased incidence of infection, decreased complication, and improved survival. So all of these can occur after good debridement. Let's move on. Now, what is this biologic dressings all about? I already told a little bit points regarding this, but let's repeat. Biological graft material that can be used for temporary coverage of burn wound include allograft, xenograft, and some other like human amnion. Now let me ask this simple question. What is the meaning of allograft and xenograft? What is allograft? Anybody?
Sir, allograft sir, it is transplantation of a cell or tissue or organ, sir, from a like so to a recipient from a non
The
from
non-identical donor to the same species.
Okay, okay. Anybody else? Now here, listen properly. These are the important terms, okay, which should be discussed under immunology. These are immunological terms. Transplantation is important topic there, and I presume, okay, it was discussed there. But if it was not discussed, so this is the time we discuss now. Okay, see here. Allo is the term we use for the same species. The member of the same species is called allo. So if I take a skin graft from another person, this is known as allograft. If we take a graft from the same person, this is called autograft. Auto is the term we use for the same person. For example, one thigh is having burn. You are taking skin graft from another thigh and okay, grafting it there. This is called autograft. Same person. Allo is a family member who is maybe donating the skin graft. Geno is from different species. Okay, for example, animal. Okay, if I use some animal tissue into the human being, this is called xenograft. So these are important point. Let's move on. Usually, this type of biological dressings, they are bilaminate structure. Outer layer is having pores to permit water vapor, which may go inside, but not liquid or bacterial passage. Just the water vapor will be allowed. The inner layer that permits ingrowth of the fibrovascular tissue from the wound surface. You don't need to know in this much detail. Just know one thing: skin graft, okay, is wonderful way of treating this type of burns. Now, why? Because the superficial layer of the skin is gone, okay, and there is a lot of dead and devitalized tissue. We need to remove everything of that. Now we need to cover that up, isn't it? And the best way to cover it up is skin graft. This is example of biologic dressing. Let's move on. Now let's go and talk about some other aspects of the burn. This is a big class, okay? So we'll talk about a lot of things here. Infection of a burn wound causes an increase in the depth. A second degree burn may convert into third degree after infections occurs there. And how to diagnose the infection? One is clinical examination. The symptoms and signs of the infection are there. And another one, which organism is causing the infection? We need to take a swab from the wound and take that swab to the microbiology lab. And if the organism grows there, that will give you the confirmed diagnosis. Burn patients are very prone to pneumonia and catheter-related infections also in severe cases of burns because they are admitted in the hospital. This may be hospital-acquired pneumonia, and some dreadful organisms are responsible there, like Staphylococcus aureus, which is MRSA type, that is called MRSA strain of Staph aureus, very dangerous organism. And another one, some gram-negative organisms like Pseudomonas and Klebsiella are the good example here. Now, regarding the treatment, for invasive infection, use topical antimicrobial and start the systemic antibiotics, both. Okay, only one is not enough. So here, use topical antimicrobials and systemic antibiotic. For pseudomonal or pediatric infection, use subscar piperacillin and plan for emergent operative debridement within 12 hours. So this is one of the way. What is piperacillin? It belongs to which family?
Penicillin.
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 Very good.
It is a broad spectrum beta-lactate antibiotic, sir.
Fine, fine. So all the answers are correct, but the broader family is penicillin group itself. There are different types of penicillin we have. So piperacillin is one of them. But absolutely, piperacillin is usually given for pseudomonal infection. You already know that. For candida infection, you start antifungal cream now, okay, like miconazole, clotrimazole, and all those things. If that treatment fail, you go for amphotericin B because this is a systemic antifungal drug. Now, there is one small diagram at the top of this slide. You can see this is a skin graft knife with a blade. And trust me, when you start working in the surgical department, okay, in a good hospital, if that surgical department is taking care of the burn cases also, you yourself are going to do a lot of this skin graft. Your senior will definitely teach you, okay? So this is how the knife looks like, and this is a blade. Now, burn debridement with a Goulian knife is frequently accompanied by a significant amount of blood loss, which can be minimized by using topical thrombin spray and infiltration with epinephrine or vasopressin. Now, why there is a high chance of blood loss here? Now, just now, okay, we discuss about this. In burns case, there is not much amount of blood loss, but this is not a similar type of case here. This is a situation of granulation tissue, and granulation tissue has good amount of blood supply. Healthy granulation tissue will bleed actively when we give a trauma there. So just to minimize that blood loss, we used to use some vasoconstrictor agent, and you can see all these things there. Okay, this thrombin spray, okay, that will help to form the blood clot there, and epinephrine and vasopressins are vasoconstrictor substance. Now, infection is more likely in patient with more than 30-degree body surface area burn. This is a very serious case without complete excision or grafting. What we do now, we need to take care of this wound very properly. Otherwise, this patient will die from infection rather than the wound itself. Okay. Remember, what happens when there is a severe infection on the skin surface? In no time, this person will develop septicemia and septic shock. Okay. And these organisms are dreadful organisms. Having said that, they are multi-drug resistant organisms because patient is in the hospital now. And these are very difficult to control. So we need to take care of those. Now with this discussion, let's move on to the different types of burn now. Now, what happens in case of flame or scald burns? What happens in inhalational burns or inhalational injury? What happens in electrical burns? And what happens in chemical burns? So let's discuss about them. Start with flame and scald. So these are the classification. It is based on the depth, first degree, second degree, third degree, and fourth degree. First degree, is limited to epidermis, skin is dry, erythematous, and tender. So the important point is limited to epidermis. Let me underline that for you. Second degree, partial dermal involvement, and here skin is blistered. Third degree, full dermal involvement. Now skin is dry, leathery, and insensitive because of the damage of the nerve fiber. And fourth degree, there is involvement of the underlying fascia, muscle, or bone. Now we have classified the general, burn, okay, the general type of burn. The fourth degree was not mentioned there. Only first degree, second degree, and third degree were there. Okay. So remember, in that general type of discussion or classification, this fourth degree is also included under third degree. But when we talk about flame or scald burns classification, then fourth degree is also there. So it's just a bit of thing there. Okay. It's not a major point. Another one is based on the size. That is according to the percentage of body surface area. And same way, okay, we classify it like a rule of 9. Let's move on. Now, how to treat it? Okay. What is a treatment? So most of the treatments are a bit similar because we have extensively talked about the general treatment of the burns. Okay, so we can go a little bit quicker here. First is ABC. Don't forget this. Some of these patients are very sick. They have unprotected airway. So airway, breathing, circulation, management, followed by full body exposure. We need to make sure of what is the percentage of the burn. Start with fluid resuscitation by Parkland's formula. Every student know Parkland's formula now. In this case, we give lactated ringer solution 4 ml per kg, which is multiplied by percentage of body surface area involved. Okay, we have done some of the class exercise as well. Give 50% of the volume over the first 8 hours, remaining 50% over next 16 hours. Give maintenance fluid volume in addition to the resuscitation volume. Remember, this is just the resuscitation, okay? So maintenance fluid, we always give it. Maintenance fluid means it is necessary for our metabolic activity in the body. So we give it, we add the other fluids there and give to the patient. Volume may need to be adjusted based on urine output, definitely. If urine output is less, we think probably fluid is not enough. We increase a little bit of fluid, but make sure patient is not in renal failure. If renal failure is already developed, then giving a fluid is very dangerous. Apply cool normal saline pads to burned area. So cold application, already talked about, and give tetanus shot. Okay, give tetanus shot if the patient has not taken, the complete series of the tetanus toxoid shot before. Topical antimicrobials like silver sulfadiazine cream is applicable in the second and third degree burn. So see that it is very commonly applicable. It is not applied on the face. It may cause reversible leukopenia. We talked about that. And it is ineffective against Pseudomonas and Enterobacter. Okay, these organisms are not covered by silver sulfadiazine. So probably we have to go for some other powerful systemic therapy for this. Okay, so can you tell me which are the systemic antimicrobial drug which cover gram-negative organism? Which are those? Gram-negative coverage.
Aminoglycoside
Inhalation, cephalosporin, macrolide.
Exactly.
and cephalosporin.
Very good. Aminoglycoside and third generation cephalosporin. If you answer like that, you're absolutely correct. Aminoglycoside and third generation cephalosporin. Even fourth generation, of course, can be used. Another topical antimicrobial agent is called mafenide acetate. You already know the name. This is a trade name there, which is very commonly used. Okay, sulfamylin can be used on face. It produces a bit of a of pain, but it has a good scar penetration. We talked about that, and it worsens acidotic condition. That's why we do not generally use it everywhere. Okay, this is a chosen type of topical antimicrobials according to the surfaces. Can be used on the face though, and in face triple antibiotic therapy can also be used. Don't neglect the role of nutrition in this type of cases. Now, why the role of nutrition is very important here? Yes, we can answer.
Sir,
Yes.
sir, because in burn cell we have lost the fluids, and sir, in the fluid we have lost different types of electrolytes and ions. Sir, for that we need some nutrition to
Okay.
fulfill that electrolytes and that everything, sir.
Okay, good. Anybody else? Anybody else want to speak here?
For the regeneration repair.
Exactly. Yes. Okay, so I accept all those answers. So see that if this type of questions are asked, the answer is very easy. Just speak, give some points in favor of the nutrition. Now remember, this second degree and third degree burn, which may be caused by this flame or scald, it's a serious patient. If more body surface area is damaged, the patient is more sicker. The patient is losing a lot of proteins from the body. A lot of exudation occurs and protein is lost. On top of that, this patient is having high chance of infection. So we need a good immunity to fight against this infection. So that is, provided by nutrition. And nutrition can be done by either, uh, enteral or parenteral. Enteral means through mouth. Parenteral is IV. And IV, feeding is also necessary sometimes in the patient if they really cannot eat anything at all. Okay, but usually, oral would be sufficient. Systemic antibiotic therapy is only for proven infection, and if local antibiotics are not enough. Let's move on. Now, what are the surgical interventions of flame and scald burns? Early grafting decreases the inflammatory response, so you go for skin graft. Grafting means skin graft. Early grafting is better. Sclerotomy, we already talked about it. Incision, okay, of those area which later on has a high chance of formation of ugly type of scar. Or in other word, if scar is formed there, then we may lose the function of that limb. Okay, so remember, in that time we need to go for incision in those areas, like biaxial for extremities, uniaxial for finger, bilateral, midaxial, and midclavicular for the chest. Biaxial means on the both side. This is the meaning. Uniaxial means only on one side is enough. So you cut that area. Don't allow the contracture developed in that area. That is the meaning. Excision and grafting, okay, is another type of treatment there. So for deep second degree and all third degree burn, we need to excise those ugly looking scar and replace them with graft. Start 2 to 4 days after admission when the patient is stable. In 2 to 4 days, there is no scar formation. But there are two points I like to highlight here. Maybe students are confused here. ESCHAR, that is also pronounced as a scar, and another is after the burn is completely healed, the final scar is also formed. That is also called scar. Okay, so don't get confused. That takes a long time to develop. The second one, the scar term which I am using here is the first, ESCHAR. So that has to be removed because the penetration of the antibiotic through that scar is less. And that is one of the standard part of our surgical therapy of the burns in all type of burns. That's what we are talking right now. Limit its surgery to 10 to 15% body surface area and limit the time to 1 to 2 hours, because longer time, if surgery is done, there will be a lot of complications of anesthesia, isn't it? And patient will lose a lot of blood and fluid from there. cover with autograft, allograft, or biobrain. This biobrain is a type of artificial skin. Okay, just a name, nothing else. So autograft, I already talked about. Patient's one skin is transplanted there. Allo, somebody else is donating the skin, and that is given. But let me ask you one simple point. Who can donate the skin? And before accepting that skin, what test should we do? Anybody?
Blood cross matching.
Cross
HLA typing,
Sensitivity.
HLA typing and hypersensitivity.
Okay, good. To see that answer is already coming.
blood type.
One is blood grouping. Okay, blood grouping. Another is HLA typing. Wonderful, excellent answer. HLA typing and blood grouping. Never forget this. Before we give any tissue, any organ to another person, those two things must match with each other. Otherwise, there is high chance of rejection. We don't want that. Very difficult, we are transplanting that particular organ, and if it is rejected, this is a waste of effort, waste of money, and so many other complications. Okay, so let's move on. Now, after this, I'm entering into probably one of the most important part of this one class, and a lot of questions will be asked to the student from this part, that is inhalational injury and carbon monoxide poisoning. Because of this carbon monoxide poisoning, this subtopic under the burns is really important. Now, let's move on. This inhalational injury and carbon monoxide poisoning is common in closed space burns. Somebody is trapped inside the house, inside the room. Okay, windows are also closed, door is also locked, and if the fire is there, that type of space, okay, commonly results in carbon monoxide poisoning. Now, another one, please listen properly. This has occurred in so many areas all over the world. Now, this is a winter season. Okay, this is winter season in the northern hemisphere. In the southern hemisphere, it is a summer season. Let's not go into those things now. Let's talk about the colder area. What we do to make ourselves warm, especially in the night time? What we do? Yes,
Heaters.
exactly. Heaters. Okay. Sometimes what people do, they burn some fire inside the room. Okay. They burn fire, and what they do, what the mistake they do, they close all the windows, they close the door. They are afraid that cold air will flow inside the room, and they will get cold in the middle of the night or in the early morning. That's the mistake they're doing, because that fire which is there will consume all the oxygen, whatever is there in the room, and that fire is releasing carbon dioxide and carbon monoxide gases. This carbon monoxide is known as a silent killer. The person doesn't realize that he's inhaling or she's inhaling that gas. Now, what happens after some time? They will become unconscious, and other people believe they're sleeping. They even do not struggle. And in the morning time, when people come and check, all the person who are present in that room die because of this carbon monoxide poisoning. So many cases we hear about this type of incidents. Okay, now that's why this topic is important. So how can we prevent a person from carbon monoxide poisoning? That's the first question. Second, if a person has already developed it, what can I do for the treatment? Let's come back to the topic now. So this is common in closed space burns. Now, the mechanism of action of this carbon monoxide, how it produces poisoning, is given here. Carbon monoxide impairs tissue oxygenation by decreasing oxygen carrying capacity of the blood. It shifts oxygen hemoglobin dissociation curve to the left. It binds to myoglobin in different tissue, and it also inhibits terminal cytochrome oxidase in the mitochondria. So let me elaborate on this, okay? These are very important points for you. So let's give a bit of time here. If we compare, okay, the oxygen carrying capacity of hemoglobin, okay, like the binding capacity of hemoglobin to oxygen and carbon monoxide, let's talk like this. It is much more higher for carbon monoxide. If a molecule of carbon monoxide is there and a molecule of oxygen is there in front of hemoglobin, hemoglobin will prefer to bind with carbon monoxide rather than oxygen. So that's the first thing. And another one, when that complex is gone to the tissue, now if it is oxygen, it can easily, diffuse to the tissue. This is called unloading of the oxygen. But carbon monoxide will tightly bind to that hemoglobin and doesn't diffuse. So what I'm saying here, it will decrease the oxygen carrying capacity of the hemoglobin by, okay, filling all those areas of the hemoglobin for the oxygen binding. That's the first thing. Second is the shifting of oxygen hemoglobin dissociation curve to the left. This is the features of hypoxia. Third, it binds myoglobin in different tissue, like in the heart and the skeletal muscle. And myoglobin is very necessary for oxygenation of those tissues. And if it binds to the myoglobin, the same effect like hemoglobin will be produced in those tissues as well. So there will be tissue hypoxia. That what happens in the heart and in the muscle. And one more thing, which is so important, it is inhibiting the cytochrome oxidase in mitochondria. This is an enzyme which is involved in electron transfer chain. That means the release of the form of energy inside the cells or tissues is also blocked by carbon monoxide poisoning. So all these features, okay, result in tissue hypoxia, and that tissue hypoxia can cause a lot of complication in case of carbon monoxide poisoning. Symptoms do not correlate well with carboxyhemoglobin level, but levels up to 10% are typically asymptomatic. What does that mean? See this. Symptoms do not correlate well with carboxyhemoglobin level. Means sometimes patient with low level of carboxyhemoglobin in the blood are having a lot of symptoms and signs. And sometimes the patient with high level of carboxyhemoglobin in the blood will not have those typical symptoms and signs. Now, see this before we go for the break. So I was talking about carbon monoxide poisoning, okay, and what is the mechanism of action of carbon monoxide in its poisonous effect. Now see here, carbon monoxide is a odorless and a colorless gas which has an affinity for hemoglobin 200 times that of oxygen. Even if you cannot remember this 200 times, just remember one sentence. The affinity of hemoglobin, okay, for carbon monoxide is far, far better than oxygen. That means if both gases are present there, then hemoglobin will bind with carbon monoxide, okay, easily than oxygen. So these are the important points here. This gas cannot be seen, cannot be smelled also, cannot be heard, but can be stopped by detecting it. There are certain detector which are known as carbon monoxide detector, and they can detect it so that we can prevent ourselves from the poisoning. Let's move on. Now see this, colorless, odorless, tasteless gas, but it's a silent killer. And people even may not realize that they are going to die because they cannot even detect this gas in the beginning. What are the signs and symptoms of inhalational injury and carbon monoxide poisoning? Patient may have hoarseness of the voice or hoarse voice. They may have cough, wheeze, bronchoria, hypoxemia, carbonaceous sputum, head and neck burns, and singed nose hairs. Now, these are the combination of signs and symptoms in inhalational injury and carbon monoxide poisoning both, okay? So just understand it like this. When a person is trapped inside a room which has caught fire, now there is a severe type of burns, okay? Especially right now we are talking about airway burns. So the nasal hair are singed or charred because of the, uh, uh, this carbon material which is gone inside, the sputum is black in color. This is known as carbonaceous sputum. And if we analyze that sputum, the carbon particles are present there. Patient will have hoarse voice because of the damage of the larynx. Okay, because of the damage of larynx, because of that hot fume or hot gas which has entered inside the airway, it will cause severe damage to the larynx. All these things are there. So these are the important signs: face or oral cavity burn, singed or scorched vibrissae. This vibrissae means nasal hair. Okay, nasal hair. They are called vibrissae. This is a medical term. Sputum with smut or profuse sputum. This smut is a small particle of the coal there or carbon material. Conjunctivitis, disorientation and coma as a result of hypoxia, laryngeal stridor. See this because of laryngeal edema. Stridor is a, I'm sure you know the meaning. What is stridor? Anybody? What do you mean by stridor? Who can answer that?
Stridor is a sound
Slider is highly pitched
on
wheezing
inspiration.
sound, sir.
Sound produced when
It
the
is a
air passes through
high-pitched
the
wheezing sound.
The disrupted airflow, sir, a very wheezing sound, a very highly pitched sound, sir.
Okay, good, good. Students are
High
answering
pitch sounds.
correctly. Very good. This is a high pitch sound which is produced if our upper airway is blocked. If our upper airway is blocked, high pitch sound is audible. That is called stridor. Now, larynx. Okay, if larynx is edematous or even the trachea is edematous, there is a high chance of stridor. Respiratory distress, patient is not able to breathe properly. There are signs and symptoms of hypoxia. Okay, these are respiratory distress. These are the symptoms we already talked about. Let's move on. Now look at this picture. Okay, you will get a lot of important information from here. There are carbon deposit, okay, on the the opening of the nose, okay, or near the mouth or on the face. Singeing of the hair, very important features of these burns. Face and neck burns. Okay, carbonaceous sputum if the patient is able to take it out, or if we examine the airway by bronchoscopy. There are inflamed oropharynx and hoarseness of the voice. All of these are typical features of inhalational injury. Now, these are the signs and symptoms of carbon monoxide poisoning. Now, let's focus only on carbon monoxide poisoning for the time being. Now, remember, every time, okay, there may not be a huge amount of fire inside the room. That fire may not burn the patient. Sometimes the fire may be in one corner of the room. The fire is there, but that fire, after consuming all the oxygen there, may lead to carbon monoxide poisoning. And the features may include dull type of headache, weakness of the body, dizziness, nausea or vomiting, shortness of the breath, confusion, blurring of the vision, and loss of consciousness as well. These are some of the important points. This loss of consciousness is very late, and after this, the person may not wake up at all, or there is a high chance of death. So in the picture form, headache, nausea, and dizziness, and the person should realize at this time, they should not think, oh, this is probably because of the cold, I am having a bit of cold these days, or because of this particular weather, so I should warm myself up, and they further may close the doors and windows. That is quite detrimental. Breathlessness, collapse, and loss of consciousness are other. Now, These are the common presentation of carbon monoxide poisoning. So many different slides are repeating the same thing because it is very important one. And in medicine, the more we repeat, the more we remember. Remember that thing. So these are the common sources of carbon monoxide. House fire, car exhaust, boilers and furnaces, and even cigarette smoking is a source of carbon monoxide poisoning. Okay, so that is one of the message we want to provide. Do not smoke. That may be a source of carbon monoxide poisoning in you. Carbon monoxide has 200 times the affinity for hemoglobin than oxygen, already talked about, and these are the common symptoms and signs. Ultimately, the patient loses consciousness and the patient may die. Now, this slide is trying to tell there are different level of carbon monoxide, okay, in the blood, and accordingly the signs and symptoms may vary or may arise. You see there, okay, if carbon monoxide is less than 10%, then no signs and symptoms may be there. No signs and symptoms may be there. But if the carbon monoxide percentage is more than that, and if it is more than 50%, then seizure, unconsciousness, and even heart attack symptoms and signs may be there, leading to death of the patient. Now, one take-home message, okay, I want to provide from this slide is, it kills the victim softly and quietly. They cannot even struggle in the late case. They cannot even struggle. Remember this. So what is the main thing here? Prevention. Prevention is the main thing in this type of conditions. Every person should be aware that carbon monoxide poisoning may occur in this particular situation or circumstances, and do not produce that situation or circumstances. That's it. Now, this slide you can do on your own. See this? These are the different level of carbon monoxide. This parts per million is the unit or measurement of the gases in the blood. See it? It's a normal level in home, or not only in the blood, in any environment per se. This is acceptable level near furnace, and ultimately, see this. If we are exposed to 12,800 parts per million of carbon monoxide, then after 1 to 3 minutes of exposure, it may lead to death. This is a very high level of carbon monoxide. So similarly, there are different levels provided here. You can see this later on, but this is just for the understanding purpose. We don't ask this type of questions from the exam point of view. Now, how to confirm the diagnosis of inhalational injury and carbon monoxide poisoning? First is X-ray. Can take chest X-ray. Okay, the chest X-ray may not show the typical features there. We can go for bronchoscopy and ventilation perfusion scan. Bronchoscopy is very commonly done here because the common type of injury is inhalational injury to the airway. We can see laryngeal edema there. We can see stenosis of the airway there. So bronchoscopy is routinely done. And ventilation perfusion scan, okay, is an advanced type of investigation. Now the meaning is ventilation is breathing and perfusion is blood flow. Now, what is the scan or mismatch here? Certain areas in our lung, okay, are having less amount of airflow but good amount of blood, or vice versa. Good amount of blood flow but less amount of airflow. This is known as ventilation perfusion mismatch. Okay, so we can diagnose this by going for BQ scan. Measure carboxyhemoglobin with ABG, arterial blood gas. Bronchoscopy reveals edema and ulceration, and BQ scanning will demonstrate the carbon particle deposition on endobronchial mucosa. See there is one picture which is provided. Look at this, deposition of a carbonated material here, okay, and there is severe burn-like picture on the airway. Now, the last part is the treatment. We have talked a lot about this, but how to treat? If somebody has it already, they cannot prevent themselves, but how to handle this particular condition? Half-life of carbon monoxide decrease from 4 hours on room air to 45 to 60 minutes with 100% oxygen therapy and 15 to 20 minutes at 3 times atmospheric pressure, that is hyperbaric oxygen. This is the excellent concept for us. So what is the meaning here? If I give 100% oxygen in high flow rate, like 10 to 12 liters per minute, okay, then the patient may recover if the patient has not reached to that irreversible stage. On the other hand, if I give that oxygen under pressure, which is known as hyperbaric oxygen, then that time is even reduced to 15 to 20 minutes. Now, can you tell me one small question I like to ask here? The hyperbaric oxygen is also used for the treatment of some other condition. What are those? Anybody?
Gas gangrene.
Gangrene, the stubborn wound, and some infection.
Very good. Excellent answer. Gas gangrene and some anaerobic infection. In case of anaerobic infection, if we provide oxygen there in that particular area, now those anaerobic organisms would die in the presence of this oxygen or oxygenated environment. So we utilize that principle for the treatment of those situations, and here also. Here, very easy concept. If I produce a high saturation of oxygen, okay, then probably that oxygen will displace that carbon monoxide from the hemoglobin. And if I provide a large concentration of oxygen, then oxygen diffusion to the tissues is also far more better. So this is the concept here. So in mild injury, use warm humidified oxygen. In moderate, repeated bronchoscopy when there is continued mucosal sloughing and the patient is unable to clear it. You help the patient to clear the airway with bronchoscopy and repeated suctioning also. And in severe type of inhalational injury and carbon monoxide poisoning, okay, you intubate the patient and probably keep the patient under mechanical ventilator. Let's move on. So this is an algorithm. This type of algorithm are very useful when you start working in the hospital or in the clinic. Okay, you assess the airway, breathing, and circulation first. These are the different things. Okay, assess the facial burn, singed nasal vibrissae, hoarseness of voice, and carbonaceous sputum production. These are clear-cut features of inhalational injury. Start the patient with oxygen. Okay, give a good amount of oxygen, then accordingly you judge what to do. Now, what are the complications of inhalational injury and carbon monoxide poisoning? The most common is pneumonia. There's no doubt about it. Lungs and airway are damaged there. So pneumonia has high chance to occur. Okay. So normal carboxyhemoglobin is 3 to 5% in non-smoker and 7 to 10% in a smoker. So this is a one small, data which I believe or I hope will discourage the smoking in our student, isn't it? So one interesting fact is, when you are with your parents or back home, you don't have that environment to smoke. But when you go back to your university, almost 100% of the students smoke. 100%. Some of the students may argue, no, sir, I've never smoked in my life. Yes, that percentage is very, very minimal. Maybe 5 to 10 only, okay, if I want to consider. So remember, there are certain indications. One of that is you will form a lot of carboxyhemoglobin in your blood. So quit smoking for this reason as well. Now with this, let's move on to the electrical injury. So what is electrical injury and what are the important points here? The extent of injury depends on voltage of the electrical current there. Now, high voltage injury will do serious damage, and low voltage injury will not do that much damage, but still, it will cause some injury to the body. Up to 1000 volt, there is increased resistance limit, further passage of the current and heating of the tissue. And more than 1000 volt, the passage of the current is not limited and tissue injury can continue. So these are some of the important points regarding the electrical injury. I'm sure you have studied these things in forensic medicines already. Deeper tissues can be very severely or badly damaged by electrical injury. Now, one interesting fact is there is an entry wound and the exit wound in case of electrical injury. It doesn't look like that severe from the outside, but remember that electrical current has one pathway inside the body and there is severe damage done in that pathway. It has a very high chance of death. What is the mechanism of this electrical injury now? Tissue damage via conversion to thermal energy. That electrical energy will be converted into thermal energy and it will lead to burn in the different tissue. Damage occurs in skin and underlying tissue along the course of the current. That's what I told you just now. And skin at the point of contact is often severely charred. Okay, this is known as entry wound of the electrical injury. Another is exit wound. That is also severely damaged. Now, let's talk some of the signs and symptoms of electrical injury. Charring at the point of contact, just now talked about it. There is severe muscle damage, and muscle damage can lead to myoglobinuria. Leads to myoglobinuria. Now, myoglobin is present inside the skeletal muscle. That myoglobin will be released into the blood, and that myoglobin will come out in the urine after it is filtered through those renal tubules. Now, sometimes, okay, if the kidneys are functioning well, and if the amount of myoglobin is less, it will pass into the urine. But sometimes what it does, it will block the renal tubules. Now, what will happen if those renal tubules are blocked by myoglobin? Yes? What will happen?
Oligouria and glomerulus decrease, no
Necrosis.
filtration occur,
Good.
renal
Good.
failure.
Good.
Necrosis.
Exactly.
glomerulonephritis.
So
Urine.
exactly. Yes. So you can simply say, this is causing acute renal failure. It's a type of acute tubular necrosis. Now, if you go back to your pathological discussion, acute tubular necrosis are of two types. One is ischemic, one is nephrotoxic. This is called nephrotoxic type of acute tubular necrosis. So it will lead to renal failure. So this is the danger. Hyperkalemia also occurs here because of severe tissue damage or tissue necrosis. Remember, potassium is a type of electrolyte which is mainly present inside the cell. When they are dead or damaged, that electrolyte will leak outside, resulting in hyperkalemia. And hyperkalemia has a very bad effect on our heart. It can lead to cardiac arrhythmia. High voltage or lightning injury may cause cardiac arrest quickly. Patient may die on the spot. Neuropathy may occur, and compartment syndrome can occur very commonly in electrical injury. You already know the thing here. The limbs, okay, are developing excessive pressure. There is massive swelling there, and there is features of ischemia now. And look at here, the features of ischemia. There is pain, there is paresthesia, there is pallor, there is pulselessness, and it feels very cold. And another term is very commonly used here. Let me write that term for you. And this is known as poikilothermia. So why this term is used here? So that everything starts with P, pain. This is ischemic pain. Paresthesia is tingling and numbness like sensation. Pallor is, pale looking appearance because of decreased blood flow there. Pulselessness, the pulse cannot be felt there, and it feels very cold, which is known as poikilothermia. So all of these are features of compartment syndrome in that particular area. You can also say these are the features of ischemia. Okay. Now, this slide is telling us related to the power or effect of this electricity on human being. See this. These are the milliampere, from 1 to 1000. Okay, 1000 milliampere is equivalent to 1 ampere. Now, this, effect of this electricity, and these are the different signs and symptoms in the patient. One very interesting point I like to discuss here is, see here, the heart stops beating if we are getting this much of electricity. This is not a very high amount, So here 100 milliampere, it is not even ampere there. Breathing stops, severe burns, and something like that. So it can easily lead to death. That's the point I like to highlight here. Now, these are some of the pictures where patient suffers from electrical injury and the different type of burns which the patient has suffered. So this is electrical burns, the entry wound. Okay, entry wound looks like this. This is exit wound. See here, exit wound. Okay, entry wound and exit wound. And look at this severe damage done, okay, to the hand. And there is only one type of treatment possible if this patient survives, that is amputation. Amputation, we need to sacrifice this particular area. So the extent of damage from electrical injury depends on both current density and tissue conduction. Two things are there. Current density means how high is the electrical current, how high is the voltage there, how high is the ampere, milliampere or ampere. It depends on that. And another is tissue conduction. The surface wound usually underestimate the extent of damage to the deeper tissue. Don't think that the entry wound is so small, so the amount of damage done to the inner part of the body is also less. It is not like that. Okay, so we hardly give importance to the entry wound there. Yes, it is important because it gives us the diagnosis, but it doesn't tell us how bad or severe is the electrical injury. So these are 5 P's of the compartment syndrome, which are very common in electrical injury. Okay, we already talked about them. Pain, paresthesia, pallor, pulselessness, and poikilothermic. Poikilothermic means cold. Now, okay, we are coming towards the end of this discussion. What is the treatment of electrical injury? Patients with loss of consciousness or abnormal ECG require cardiac monitoring. They require cardiac monitoring for 48 hours, even if there are no further arrhythmia or ECG changes. Now, I like to ask a question here. Why? Why we need cardiac monitoring, even if there are no signs and symptoms at the time being? Why? Anybody?
Sir, because there will be necrosis and will cause hyperkalemia and later will cause arrhythmia.
Good. Very good explanation. Excellent. Okay. Another point I like to add there on his answer, there may be release of the myoglobin. Those myoglobin will cause obstruction of the renal tubules that may cause renal failure. Renal failure leads to hyperkalemia, and again the same thing. So because of this, we need to monitor, okay, the ECG to make sure whether there is no any cardiac arrhythmia or not. Electrical injury is more likely than other types of burn injury to necessitate fasciotomy because deep tissue edema may be extensive, causing compartment syndrome. Compartment syndrome very commonly occurs in electrical injury. So fasciotomy is the treatment for compartment syndrome. Remember this. You cut the fascia, allow that pressure to dissipate outside, and the limb will be saved. But if you do not go for this treatment earlier, then you will lose the limb of the patient. So these are some of the important points. One another treatment which we can highlight here is called fibulectomy. Now, fibula is the bone of our leg. So that one small part of the fibula can be sacrificed. This will also done in some of the center, because fibula doesn't contribute that much to the weight bearing process. Late complications of electrical injury would be delayed hemorrhage because of inadequate wound exploration, debridement, or exposure of the vessel. The blood vessels may not be that coagulated, okay, if I compare with other types of burn. So there is still a chance of hemorrhage in this case, and there is a chance of cataract formation because of the damage done to the lens because of this electrical current. What is cataract? Anybody?
Sir, cataract is the opacification of eye, and sir, from opacification we mean, sir, there is a cloudy or opaque color.
Good. Very good. Is absolutely right. Cataract is a opacification of the lens. Our lens, okay, is clear. Okay, it is transparent, I should say. When there is a bit of clouding develops there, when it is opaque, we call that cataract. The most common cause of cataract is senile or because of the old age. But in this case, it is not. It is because of electrical current damage to the lens. Now, one small part of this burn topic, this is a big topic, and very important from the exam point of view also, is a chemical injury. Chemicals like acid, like alkali, they also leads to severe burn of the body wherever they come in contact. So let's talk about them. Regarding the mechanism of injury, okay, they lead to protein denaturation and precipitation with release of thermal energy. So this is their mechanism of action. You can remember like this. Underline this: protein denaturation and precipitation. And after that, the thermal energy is released, which will lead to more damage. Alkali can lead to liquefactive necrosis. This is a type of necrosis. You already know there are different types of necrosis. This is one of the type. Petroleum product, they can also burn. Petroleum product, they can lead to delipidation. They can badly damage the lipid tissues, okay, which is known as delipidation. So petroleum products like kerosene, like petrol, like diesel, and all these things. Vesicle formation is done by vesicant gas. Now the meaning of this vesicant gas, these are the blister agent, also known as vesicant, are cytotoxic alkylating compound like a mustard gas. So they can also lead to chemical burn injury. Okay. One of the important point is the strong acid burns may leave a deceptively healthy appearance of tan, smooth skin, but the underlying surface is very, very badly damaged. So if there is a history of acid or alkali injury, we should take it seriously all the time. Let's move on. Now, how to determine the severity of this chemical injury? It is determined by concentration, okay, the amount of agent in contact, and the duration of contact. The concentration means how concentrated is the acid or alkali. High concentration will of course lead to severe damage. Amount also matters here. If the amount which is in contact is more, it will of course leads to more damage, and duration of contact also is an important point. If a person quickly washes that area with a water, okay, with tap water is enough for the washing, then the severity of the damage or injury may be minimized. You must have heard about different types of acid attack in different parts of the world, especially in India. This is so common in different parts of the India. We have come across with these different incidences, acid attack, especially in females. Okay, so these are a good example of chemical injury. Now, what are the priorities in treatment? Remove all cloth to prevent further contact. So why we need to do that? Who knows? There is still some of the chemical substance which is leading to burn or injury on the cloth. So remove all the cloth. Copious water lavage, very, very important part of the management. Okay, this is also known as irrigation. Thorough irrigation must be done as quickly as possible. And it should continue for at least 30 minutes. At least for 30 minutes for acid burns. See this? And even longer for the alkali burns, because these alkali, they penetrate deeper into the tissues than the acid. Check pulmonary status of the patient, means whether there is any edema of the airway or not, any mucosal desquamation or not, and any bronchospasm or not. So how to examine them now? Anybody? How to examine these things?
Bronchoscopy, sir.
Bronchoscopy, sir.
Bronchoscopy.
Exactly. Absolutely correct. This is done by bronchoscopy. That's why this bronchoscopy is a very important step in the investigation here, or a part of examination. It will tell us whether there is laryngeal edema or not, whether there is bronchospasm, okay, or narrowing or not, and whether there is extensive damage to the mucosa which leads to desquamation or not. All of these can lead to obstruction of the airway, and patient may die simply from this. And remember, whenever a sick patient comes to us, the first priority for us is airway management all the time. Airway first, after then breathing, and then only circulation. So chemical wound irrigation should be done with water only. Now, sometimes what we think, oh, this patient is having acid burns, and we all know alkali will, okay, neutralize the acid. So why don't we put alkali there? That is a very, very, detrimental, or what should I say? It's a bad type of thinking to the patient. It is damaging type of thinking, because when they react with each other, there is a release of heat, and that heat will further damage the tissue. So the best thing we can do is irrigate or clean with water only. Tap water is the best, because there is a good amount of pressure or force in the tap water, and it will really help to flush that excessive amount of a chemical material there. Okay. Now, a little bit about nutrition of the burn patient, though I already gave a bit of concept in the beginning. There are two types of nutrition. One is enteral, another is parenteral. Enteral means through the intestine, through the oral cavity, or through the alimentary tract. Parenteral means IV or intravenous type of nutrition. If enteral is not possible, then only we go for parenteral nutrition. That is also known as total parenteral nutrition, or TPN. Okay. Early feeding is recommended in case of burn, because they need calorie, they need energy to fight against the infection, which may have already occurred or may come later on in a case of burn case. And high amount of protein is also necessary. Now, okay, we have come towards the end of this big topic. There are certain guidelines which are prepared by American Burn Association. Okay, now what are these criteria prepared by American Burn Association, which may help the uh, the young doctors, or the doctors, we call them general physicians or family physician. They are the one who look after the patient for the first time. What are the referral criteria for them? In which situation they need to refer these cases to the burn specialist or burn center. See there? Partial thickness or full thickness burns of more than 10% body surface area in patient less than 10-year or more than 50-year-old. It may be complicated one. That's why partial thickness or full thickness burns of more than 20% body surface area in patient of other ages. In less than 10 or more than 50-year, more than 10% is enough, but in other ages, we need more than 20%. Partial thickness or full thickness burn involving face, hand, feet, genitalia, perineum, or skin over major joint. High chance of complication occurs if these areas are burned. That's why we need to refer in time to those consultant. Full thickness burns more than 5% body surface area at any age. See this, full thickness is a severe type of burn. Significant electrical injury, including lightning, always take it seriously. Refer them early. Significant chemical burn like acid or alkali. Lesser burn injury in conjunction with inhalational injury or other medical condition. And burn in patient who require special social, emotional, or rehabilitation assistance like child or elder abuse. Refer them quickly.